Okay. So I realized just this morning, and I thought I changed it, that the muscle completed notes that I was supposed to take these blocks off. It's just basically boxes that I filled in so I could go over it slowly with you guys. I'm going to update that after lecture because obviously you want to see that stuff. Whether or not it's important, because did anyone not get the email I sent out with the exam 2 breakdown? I sent that out, I think, yesterday. Yeah, I know I did. Okay, so that is what you need to study, okay, out of all the stuff. But I will fix this completed notes on the web page. Okay, any questions? Because I just found out some of you guys taking anatomy have an anatomy exam next Friday, which would be just before our exam. So that's unfortunate. I do try and shift, like I tried to shift the first exam so it wouldn't fall when most other people were having their first exam, but it doesn't always work out perfectly. So yeah, I feel for you. All right, so just try and budget your studying time. Now that you've got the exam breakdown, you've got kind of a narrowed in list of things you got to study. All right. So yeah, and then spring break. I'm probably more happy than you guys are. I don't know. I'm going to Florida, baby. Okay. So this is the chapter that everyone loves, cardiovascular system. It's fun. You guys got in anatomy, got to look at the heart models and all that stuff. So you kind of got a feel for it. But we are going to do a quick review, but then we're going to go where anatomy doesn't go and talk about physiology of the heart. Fortunately, since we've covered the effect of acetylcholine and its muscarinic cholinergic receptors and epinephrine and its beta-1 adrenergic receptors, when I get to that stuff, that's going to be all review for you guys because you got it down now. I think you do. So quick review. All right. This is obviously going to take, I don't know, today and Monday and Wednesday of next week. And then we have the exam, and some of this material might still wrap around until after that because there's a lot to cover. So quick review. Let me get my little laser pointer here. Okay. So you guys should have this down, right? So when oxygen poor blood comes back to the heart, they all converge on the superior vena cava. And here's the inferior vena cava. And then that blood enters the right atrium. And this valve right here, number 3, what's that called? Tricuspid. It's also called the right atrioventricular valve or the right AV valve. And then that blood enters the right ventricle. So the right side of the heart is processing oxygen poor blood or deoxygenated blood. But I don't like to say that because it's screwed up. So I say oxygen poor blood. All right. And never should the 2 types of blood mix. And we will talk about that. I don't think they've talked about that in anatomy because, well, they're just concerned with the chambers and the valves. Okay. Now the blood from the, sorry about this, trying to get it out of the way. Blood from the right ventricle goes up into this vessel right here, colored blue, but it has to pass through this valve I've numbered 5. What's that valve called that leads to this big blood vessel here? Pulmonary semilunar. Okay, so a semilunar valve separates a ventricle from a blood vessel. In this case, it's named according to where's it heading to? The lungs. Pulmonary means lungs. So the pulmonary semilunar valve, and then we've got the pulmonary trunk labeled 6 right here. And then that bifurcates off to the left and the right. Okay, here's where it can get tricky. Because it's carrying oxygen poor blood, in textbooks color blue, and that's correct because it's oxygen poor. And it's called pulmonary something. Pulmonary, is it pulmonary artery or pulmonary vein? Pulmonary vein. Nope. That tricks you up. If arteries always go away from the heart, veins always return to the heart. And that is regardless of whether it's a pulmonary circuit or the whole body systemic circuit. Arteries always go away from the body. So these 7 and 7 are pulmonary arteries, and they're going to the left and the right lung, going to drop off the CO2 waste and pick up oxygen, come back oxygen rich, and that's why textbooks color them red, and they're pulmonary veins because they're returning to the heart. And they dump their blood into this upper chamber here called the left atrium. This valve labeled number 10 is the bicuspid. It has many names. Bicuspid, left atrioventricular valve, or there's a third name just to mess you up more. Mitral. I don't know why they have so many names for it, but they do. Okay, and then we're into the left ventricle. Please note the thickness of the left ventricle is much greater than the right ventricle, because when the left ventricle contracts, we're going to learn ventricular systole is called. It has to pump. It has to contract with enough force to push blood out of the heart into arteries with enough blood pressure to travel to all the parts of the body. And so that is why the left ventricle is much thicker than the right. Okay, so now the blood's in here and it's hard to see, but it's labeled number 12. That valve is the aortic semilunar valve. And then the blood goes into the ascending aorta, the arch, and you got 3 blood vessels, which I show up there, the big blood vessels, and then the descending aorta right here. Okay, so that's your quick anatomy review. So let's do some more review because I assume that you've had this in anatomy. Oh, my advanced slide isn't working, so why are you all frozen up on me? Maybe it's because I got the laser pointer on? I don't know. Who knows? Let's see. There we go. Okay, the pulmonary versus the systemic circuit of blood flow. So basically what I've described to you before in the previous slide was the pulmonary circuit. It starts when the oxygen poor blood enters the right side of the heart at the right atrium, and it actually ends with the pulmonary veins. That's the pulmonary circuit. Get blood into the right side of the heart, pump it to the lungs, to get oxygen, return to the heart. The systemic circuit officially, you look at textbooks, starts at the left atrium, because that's where oxygen-rich blood enters the heart, and then it's going to be pumped out to the rest of the body. Oh, now it's working. All right, so systemic circuit, that's what's going to the whole body, starts at the left atrium right here, and then the left ventricle, out the aorta, and then to ever decreasing size of arteries till it gets to the rest of the body and has gas exchange. Okay, so arteries always travel away from the heart, even if it's the pulmonary circuit. So remember that, don't get tripped up by it. Veins always travel towards the heart. Now, in the systemic circuit, what those vessels are carrying is different. If you're in the pulmonary circuit, pulmonary arteries are traveling away from the heart, but they're carrying oxygen poor blood on its way to the lungs. So you have to remember what it's carrying is different. And pulmonary veins, yes, they're traveling back to the heart, but now these veins carry oxygen-rich blood. So that's just the only switch up. All right. Now, people who are taking anatomy right now, have you already finished the heart? No, you haven't gotten to it yet? Okay, well, this would be good review for you. Now, this is where I don't think they cover in anatomy. They might, but as future nurses, you're going to have to know the lub-dub sound. Lub-dub, lub-dub, lub-dub. The typical heart sound that you're listening to through your stethoscope, and it's called auscultation. All right. And I know at the nursing program in the lab space on the second floor, they have a audio device with 30 different heart sounds that you're going to have to learn. The normal heart sounds and then abnormal heart sounds. And it's going to take practice, but you'll get very good at it. And you'll hear, oh, that person has crackles. There's fluid in their lung. Oh, they have a split S1. They have a split S2. Oh, they have a Kentucky Gallop in their heart. That means nothing to you right now, but it will when you get into the nursing program. So ventricular systole is when, nope, I don't want the thing. I don't know why it does this to me. Come on, get the pen. Okay. It's when the ventricles are contracting. Okay. Now, when the ventricles, here's the right, here's the left, when they're contracting, the AV valves above them must be closed. All right. So I'll say the tricuspid and bicuspid valves. Snap shut. Just like at microseconds before the ventricles contract. So these, if I were to say that, I say the valves shut first, then the ventricles contract. And the timing must be perfect. Okay? Because if the valves do not shut, okay? When the ventricles contract, it will push blood back up into the atria. And that means less blood is going to get to the lungs, less blood gets out through the aorta, and that means your body's going to get less oxygen. Coming off the heart, one of these is the left common carotid or the common carotid artery. And then it splits into a left and a right, and it brings blood up to your brain. Before even that, coming off the ascending aorta, doesn't show it in some textbooks, but there is a little place here where your coronary arteries, common coronary arteries, blood comes out to feed the heart itself. So if those valves don't shut simultaneously before the ventricles contract, less blood is going to get to the heart, less blood with oxygen is going to get to the brain, and you're going to have major problems. And in general, problems happening on the left side of the heart are more major than problems happening on the left side of the, right side of the heart, because this is where you're processing oxygen-rich blood. So this thing that you're listening to through your stethoscope is actually really important. And I think that maybe in anatomy you understand it. You understand the chambers and the valves, but the timing of the events that happen are so important that if they're off, you can hear it through the stethoscope. And we're going to listen to some sounds. That's why I was doing a sound check at the beginning here. Okay. So anyway, that's the lub or S1 sound. It's called the S1 sound. Now, ventricular diastole is when the ventricles are relaxed and filling. With blood. And when that happens, the semilunar valves must be snapped shut. I'll just put semilunar. And that is equally important, because what you don't want to have happen is while the ventricles are filling with blood, okay? So blood from the atria, they're full. The tricuspid and bicuspid valves open passively from the pressure of the blood in the atria. Fluid trapped in confined spaces has tremendous pressure, and that pressure forces the tricuspid and bicuspid valves open. All right, and so the ventricles are relaxed and diastole filling with blood. And then you must have the semilunar valves snap shut so some of that blood doesn't get out into the blood vessels prematurely. You want to wait till the ventricles are maximally full. That's the most efficient thing for the heart to do. So when the atria contract, they inject the last little, like 25% of blood they have into the ventricles. The semilunar valves are still shut. And now we've got tremendous pressure of the blood in the ventricles because they're maximally full. They push open the semilunar valves passively. Then the ventricles contract and inject the last little blood they have into the aorta or the pulmonary trunk. So this I don't have written down anywhere, but I want to explain to you the importance of these events. Because if you hear abnormal sounds, like you're supposed to hear lub-dub, lub-dub, lub-dub. Oh, that's nice, lub-dub. All right. If you hear lub-lub-dub or lub-dub-dub or lub-whoosh-dub, that's abnormal. That's not good. All right. That's significant. Other thing that's significant is absence of heart sounds. Come on, go away a little. My pen is just, it's Friday. It doesn't want to cooperate with me. Okay. Absence of heart sounds. Obviously that is crash cart, crash cart. We need to get this person. We need to revive them. Their heart stopped. Okay. So what I've got here is a little GIF showing you what's happening. The atria fill, push open the bicuspid, tricuspid valves simultaneously. Then they contract and push the last of their blood into the ventricles. At that point, the ventricles are full, right? Ventricular diastole, they're filled with blood. Then the ventricles enter ventricular systole, where they're going to contract. All right. But the semilunar valves will open passively because of all the pressure of the blood filling the ventricles. And then the ventricles contract during systole, push the last little bits of blood they have into their blood vessels. So this lub-dub thing that you're listening to, S1, S2 sounds, you're going to learn a lot of heart sounds, okay? And begin to recognize the abnormal sounds. The lub and the dub. The lub is the sound of the AV valves closing. The tricuspid and the bicuspid valves close, they snap shut. That's the lub sound that you're hearing. When the semilunar valves close simultaneously, that's the dub. Those valves closing simultaneously. So the lub and the dub is the sound of the valves closing simultaneously, and they must close simultaneously, or else there's problems. And so the timing of those events is very important. That's why measuring an EKG and the heart's electrical activity when things are happening are so important. You can pick up when there's problems, all right, as well as being really good at listening to heart sounds. And you know, when you listen to heart sounds, you're going to find out in nursing, there's many places on the front and on the back that you will auscultate for heart sounds. It's very complicated. It seems simple, but it's very complicated. Okay, so in ventricular diastole, the ventricles are filling with blood. The tricuspid, bicuspid valves are open. The semilunar valves are closed. Okay, so that's filling, relaxed and filling. And then systole is when the ventricles are contracting. Now, is there an atrial diastole and systole? Yes, when the atria are relaxed and filling with blood versus when they're contracting. But most often, you're concerned about what's happening in the ventricles. Okay, and if you're online looking at this PowerPoint, you can look at these simple little GIFs if you wanted to. Okay, heart murmurs. Heart murmurs can be innocent, not pathological, or pathological. This is what you're detecting when you're auscultating, all right? Now, I had an innocent murmur when I was a child. Kids come out, they're not fully baked yet. Lots of organ systems are not fully functional. So I remember, going to a doctor for a regular checkup, and they detected a heart murmur. They said, oh, they got all scared and freaked my mom out, and they sent me to a specialist a couple towns away, put all the sensors on me. Come to find out, it was just an innocent murmur. Children can sometimes have an innocent heart murmur where you get a quiet whoosh in between the lub and the dub. The valves aren't closing simultaneously, and so some blood backs up, like say from the ventricle to the atrium. So an innocent murmur is a quiet, I'll say whoosh, between the lub and the dub. And I'll say can be normal in children. They outgrow it. Right? If they don't outgrow it, then there's a problem. Now, if an adult, oh, sorry, I don't hit the screen somehow, did that. If you have a whoosh sound, and that's why I was testing the sound, is I'm going to have you listen to it between the lub and the dub as an adult. If it develops once you're already an adult, that means a pathology has set in. Adults should not have a murmur. That means, so when you're listening and auscultating and you hear something that doesn't sound like a nice crisp lub-dub, that's clinically significant, all right? So if you, the nurses, are doing a basic exam and you hear an abnormal sound with the lub-dub, you need to let the doctor know that, because you have to pursue that further and find out what's going on, because it could be serious. Okay, so now I'm going to flip this around so I can control the volume here. I'm going to try it really loud, and I'm sorry if it's too loud when it comes up. AV valves closing, semilunar valves closing. Okay, perfect. No whooshing in between. The lub is crisp. It's not lub-dub. And the dub is crisp. It's not lub-dub-dub. All right. Those are called either a split S1 if it's with the lub, or a split S2 if it's with the dub. That's abnormal. That's not supposed to happen like that. Okay. So in a pathological murmur, something that shouldn't be happening, if the valves aren't shutting simultaneously, crisp lub, AV valves closing, crisp dub, semilunar valves closing. If one valve is closing slightly before or after the other, and chambers are contracting and ejecting blood, blood is going to go backwards. So like the ventricles, if blood from the ventricles ejects into the atria above them and instead of into the pulmonary trunk or the aorta, that's called regurgitant flow, like regurgitate, throwing up. It's things are moving in the opposite direction of what they should be moving, and that's bad. And the whoosh sound is that regurgitant flow. You're hearing blood whooshing through a valve that wasn't closed when it should be. All right. Now, some things that can cause this regurgitant flow. And some people, the valves can be defective. In this case, the stiffening of the aortic semilunar valve, so the valve that separates the left ventricle from the aorta, that valve can become stiff due to a disease process. And stiff things aren't flexible. And a stiff valve is not going to snap shut like it should. Another thing that can happen, and this is just a short list, rheumatic heart disease. So I've talked about autoimmune disorders before. In this case, your immune system goes after the valves in your heart, and chronic inflammation by this autoimmune attack causes the valves to put down scar tissue and they become stiff. And especially it tends to go after the bicuspid, which is between the left ventricle and the aorta, all right? And that's a problem. These are the common enough things that you're going to see them as nurses. And there's a whole laundry list of other things that can cause pathological murmur. So I'm going to give you an innocent murmur sound, and hopefully it's going to be loud enough. That whoosh sound, that's regurgitant flow. All right. How are you going to know as nurses what's an innocent murmur or a pathological murmur? Obviously, age of the patient and overall health of the patient. Okay. Like I said, you're going to learn 30 different heart sounds. Here's what aortic stenosis sounds like when the bicuspid valve has been stiffened. Obviously not normal. That whooshing sound is the valve's not closing and the blood is regurgitant flowing. And I'm not going to go through all of these, but here, let's see. A split S2, a split dub sound, lub-dub, and there's lub-dub-dub, but it's so close. You have to really listen. You have to get a really good ear for these things. That last sound, the S2, there's two little sounds in there, not one. Okay. So you guys will get really good at this at some point listening to a practice. You get so good at it, just like measuring blood pressure, you get really good at it. The first time you do it, maybe not so good, but as time goes on, you do it on a regular basis daily, you're going to get really good ear for these things. Okay, so if you're curious about all these heart sounds, I got a really good webpage. If you click down here, you can listen to the Kentucky Gallop and the split S1 and all these sounds. It's really cool, but you do have to have earbuds because it doesn't play loud enough through the microphone on your computer. Okay, heart defects continued. So when babies come out, they're not fully cooked. Often things are not the way they should be because the systems are still forming. And often when a baby is born, before they're born, there are often several holes in the heart. And it will close by the time the baby is born, because once the baby is born, they're on their own. They have to get in their own oxygen and get rid of it, and, get rid of CO2. But before they're born, having these holes in the heart as the heart is forming is not a big deal because mom's circulatory system, through the umbilical cord, through diffusion, is providing all the oxygen and getting all the CO2 waste out of the baby's body. But when they're born, they're on their own. And so if those holes that were in the heart haven't closed yet, that could be a problem. So let me turn this back around again so I can write. So a patent foramen ovale. Patent means open, and foramen is another word for a hole, and really ovale is the shape of a hole. Now don't get this confused with the foramen ovale hole in the cranial, in the skull. That's different. This is a hole between, whoop, I lost my pen. Come back. I need you. There we go. The right and left atria. as this hole shows. Here's the right atrium, over here is the left, and they're showing a hole between them. In a fetus, that hole is there. It should seal up by the time the baby's born, but if they're born and isn't sealed up yet, what's happening is oxygen poor blood over here is mixing with oxygen rich blood. It doesn't really matter that much that oxygenated blood gets into the right side of the heart. What matters is that oxygen poor blood is diluting the oxygen on the left side of the heart. So when the ventricles contract, or the left ventricle contracts, less oxygen in the blood is now heading to the heart itself and the brain. And several cardiac cycles of that, you're going to have a problem. All right. All right. Another hole is patent ductus arteriosus. That is a hole. I don't know why my laser pointer does that, but it seems to want to do that. Between the pulmonary trunk and the aorta. It presents the same problem as the other hole. All right, now the heart model that's in the anatomy lab, I'm sure you've all seen it or will see it soon. If you look at it closely, the big heart model, because it's got more detail than the little heart models that are in the torso models, there is a little connective tissue. They show it with plastic because it's plastic. All right, connecting the pulmonary trunk to the aorta, but it's closed. And all that's left in an adult heart is just like a little connection of connective tissue between those two blood vessels. In a fetus, it was open. So when the baby's born, hopefully that is closed off and then becomes connective tissue. So check the heart closely and you'll see that connective tissue between the two vessels. And the same problem, oxygen poor blood is diluting the oxygen rich blood, and then your heart and your brain with the next cardiac cycle gets less oxygen. And then a really big hole, is when you have a hole in the interventricular septum. Okay. Now, I don't know because I'm not a doctor or a nurse, and I didn't really see these in animals because usually animals, they have these problems when they're born. They're dead before they get to the vet clinic. How bad are the holes? Do they intervene immediately? Some of these surgeries to repair these holes can be done before the baby's even born. They will do surgery on a fetus while it's still in utero. Isn't that insane? If it's a bad enough hole, and I think when this baby's born, this is going to be a problem. All right. They can actually do repair surgery before the baby's even born. All right. So I don't know what crazy stuff you guys are going to see, but it's going to be amazing. Some of the things you're going to see. Okay. So covered a lot of stuff here. Let's check the time. We're good. Okay. So the timing at which the AV valves close and the semilunar valves close and the electrical impulse that leads all these events to happen are very important. So you can measure the heart's conduction system, which is the heart's electrical activity. That's another thing that's routinely done. And they have actually EKG technicians. You can get an associate's degree, technical degree, because it's actually quite complicated. We have an EKG sensor in the lab. It's got 3 pads, 3 sensors. A real EKG trace reading can have as many as 13 leads. Has anyone ever seen this done in a hospital setting, an EKG? That sensor's all over the place, all right? Because they're trying to look at the heart's electrical activity from different perspectives. So number 1 includes this activity and this activity. The SA node equals the pacemaker, where, come on, Pen, where the action potential starts. Okay. So the SA node stands for, come on, Pen, sinoatrial node. It's called sinoatrial because it's, sorry, I don't know, I touched the screen. This little yellow thing right here, right up here, that's the heart's pacemaker right there, okay? The heart sets its own rhythm. The action potential starts out spontaneously. So have you ever seen those crazy sci-fi movies where some person reaches into someone's chest cavity and rips out their heart, and the heart's still beating. Right? First of all, I don't know how anyone would have the force to go through the thoracic cage, the rib bones, and actually get the heart. But technically, if they could do that fast enough, the heart would still be beating on its own until it runs out of oxygen and glucose. It'll beat for a while. Okay? So that's cool. Because the SA node sets the heart rate, and that electrical impulse, the action potential, starts spontaneously. Okay? Now, things can affect how fast the pacemaker sets those action potentials or how slow. If acetylcholine is ruling, that's binding to muscarinic cholinergic receptors on the heart's pacemaker muscle cells, the rate of depolarization or action potentials goes down. If it's epinephrine binding to beta-1 adrenergic receptors on that pacemaker, the rate of the action potentials forming speeds up. So whatever the rate is here and what's affected by neurotransmitters, the rest of the conduction system will transmit those action potentials at that rate, but that rate is controlled right here. Okay, so SA node, AP starts and jumps from the right atrium to the left atrium, and I hope you don't mind me just using R and L, and both atria contract. Right, so that's step one. Signal starts here, immediately jumps over to the left atrium, and they contract simultaneously to eject the little bit of blood they have left in them into the ventricles. Now at the AV node, which is shown right here, okay? So AV means atrioventricular node, is where the signal, and when I say signal, I mean the AP, action potential, pauses briefly to allow ventricles to fill. Allow. Right. So that AV node slows the action transmission of the action potential just briefly enough to allow the ventricles to fill maximally with blood. All right. It's not shown here. They're not showing blood in there, but that's what's happening. You want to make sure the ventricles are maximally full. So when they do contract at the end of this, a lot of blood goes to the lungs and a lot of blood goes into the aorta as maximal as possible. Okay. A bundle of His, number 3. Oh, lost my pen. Come back. It's kind of annoying. Come on, baby. You can do it. Is where the AP is in the intraventricular septum. So technically, this is before the ventricles will contract. It's just getting to the ventricles. When the signal actually radiates out into the outer walls of the ventricle, that's the Purkinje fibers. So the AP, come on, pen. You're misbehaving today so badly. There we go. The AP is in the outer ventricular walls and the ventricles contract. Okay, you can measure this electrical activity, and it gets really complicated because we've seen EKG trace. The most important thing you're looking at is the interval, how long it takes the signal to get from here to here to here to here. And there's normal ranges. You're going to learn those, okay? Or the EKG technician will. And then you also look at how big the waves are, and that's a measure of how strong the chambers are contracting. That is important. So what we have going on, signal starts in the pacemaker, jumps across to the right, the left atrium. They contract simultaneously. It pauses to make sure the ventricles are full. Then the signal after the AV node goes to the interventricular septum. That's the bundle of His. I don't even know what His stands for. I didn't look it up. Oh, well. And then when it goes into the outer walls, that's the Purkinje fibers, and the ventricles contract simultaneously. So I always have a story to tell about EKG traces. I'll get to it. So here it is, starting here. They don't really show it jumping across the left side here, but they're showing starts here, pauses here, goes down here, goes out here. All right, so if we look at an actual heart, that shows it. Starts here, jumps across here, they contract, eject their blood into the ventricles. The signal pauses to make sure the ventricles are full. Then the signal goes down the bundle of His out into the outer walls, Purkinje fibers, the ventricles contract. How important is this to measure on the EKG? Very. So your EKG looks like that, right? There's a P wave, a QRS wave, and then a T wave. The P wave, which right here, okay, is when the atria contract. And they're supposed to be doing it simultaneously. The QRS, which is such a big deflection, it's a big electrical activity in the heart. That's when the ventricles contract. Okay. At the QRS wave, basically the action potential has reached the Purkinje fibers. And the T wave is when the ventricles relax. So technically the QRS wave represents ventricular systole. And the T wave represents ventricular diastole. So I don't know if we're doing the EKG reading this semester because I don't think we do. Our sensors need to be calibrated, just like all sensors need to be calibrated. But I'll tell you a story about how important these EKG readings are. And it happened right in our physiology lab. A close friend of mine who went to grad school with me and my husband, we got here and got jobs here as faculty. I started teaching anatomy. I used to teach anatomy and then physiology. And so this other person, his name was Cedric, there was a job opening like there often are. He came and he applied for it. He got it. And he was teaching anatomy, doing a great job. And then he would be teaching physiology labs for me because we were trying to train him up to be another human physiology instructor. So I love doing it every semester, but eventually they're going to want to get two people so they can, offset it every semester. So he would sit in on the labs like on a Monday, so he would know how to use the equipment for his lab later in the week. And so we're doing the EKG lab. And so he was sitting off, one table with a computer and the sensor, like you've already used that, right? Instead of the muscle dynamometer, it was an EKG sensor. And he plugged himself up with these things and he was running it. And as my students are doing it, he goes, I don't think I've got it hooked up right. I'm getting weird readings. And so I look, because that can happen. And the sensors are so finicky. If the wires are bent or anything. So I looked at it and I said, okay, let's try this, straighten these wires out. And I was getting the same reading on him. Okay, I said, all right, let's try closing Logger Pro off and turning it back on again, because sometimes that works. Same thing. I said, okay, let's try a different sensor and grab one from a different table. Tried that. Same reading. Let's try a different computer. Okay, same reading on him. All right. And what he had, come on, pen. It's kind of anticlimactic when my pen does this to me. He had a P wave QRS like that. And actually the QRS was kind of elongated. His T wave was being buried in the QRS wave. That's what I saw. And I just thought it was the equipment. And so I said, okay, I'm going to hook the sensors up to me and run it on me. I get a beautiful EKG trace. And I'm like, I think this is real. I think you should go see your doctor. I've tried everything and your reading's constant. And it's not the sensors, it's not the computer, it's not Logger Pro. And he did. And they couldn't figure it out here at McLeod. So they sent him to Duke in North Carolina. Lots and lots of tests later, found out he had a major heart problem. It's called cardiac amyloidosis. His body was putting abnormal proteins down in his heart. And basically they said, there's things we can try. But he looked it up on the web. He said it's a death sentence. And he did die 3 weeks after being diagnosed. So what you're doing with these patients, the auscultating, looking at EKGs, all this stuff actually means something. And it's a terrible story for me and I'll never forget it, obviously, because I wish I could have had him do this lab earlier. Maybe we could have saved him if we found out before it got really, really bad. Anyway, what you're doing is really important and it actually means something. It's telling you something, okay? So that's my story about a simple EKG reading. And when you see something that doesn't look right, all right? Well, anyway, not a great way to end a Friday, but it is important what you guys are training to become and what you will eventually do. It's going to be very relevant to people's lives, all right? So this is the image from the textbook. I just snapped it. So P wave indicates that the atria are electrically stimulated to pump basically the atria contract, the ventricles contract, and then the ventricles relax. All right. And there's actually a little U wave, but I'm not going to get into that. But it should classically look like that. And it's all computerized now. And the computer can automatically measure the time it takes from the impulse to start here. It's called a PT, it's not a PT, a PQ interval. And then there's how long it takes from the Q to the S. And there's a time it takes from when it starts at the atria to ends at that's a PT interval. All these intervals, there's going to be normal values for them. And it's going to be microseconds. And if those intervals are off, the heart's electrical activity is off. And that's a major problem. All right. So let's go back to something we're familiar with. So the heart's pacemaker starts the AP spontaneously, but how fast action potentials form or how slow is affected by the neurotransmitters that you know also well at this point. So if it's sympathetic innervation, and is the thoracic tense you up nerves, and also the cardiac, the heart has its own nerves. The neurotransmitter that rules the sympathetic system is epinephrine, known as adrenaline. The receptor for epinephrine on the heart's pacemaker is beta-1 adrenergic. Okay, that will increase heart rate. What's happening, if you look at a textbook, I just say increased heart rate. They will say increased rate of pacemaker depolarization. That's just a fancy wordy way of saying the heart rate goes up. And if the rate of depolarization, the rate of action potentials forming in the pacemaker increases, then it's increased throughout the rest of the conduction cycle. So that higher rate goes to the AV node, the bundle of His, and the Purkinje fibers. It follows it. They just do what the pacemaker tells them to do. Now, if it's parasympathetic with on vacation vagus nerve, the neurotransmitter is ACH. Its receptor is called muscarinic cholinergic. And so we're talking about what's happening in the pacemaker, and then the heart rate goes down. So you have a slower rate of depolarization or action potentials forming. And then that slower rate follows through the AV node, the bundle of His, and the Purkinje fibers, because they just do whatever the pacemaker tells them to do. Okay. All right. How's the time? We're doing okay. Now, this is also review. I told you you'll never be able to let it go. If the heart pacemaker depolarizes or forms, I hate you, little thing. Look at that. Can you believe that? Forms. It's playing with me. It's a Friday. Forms action potentials. Okay. So when that epinephrine is binding to the heart's pacemaker beta-1 adrenergic receptor, what ion channels are open? What are the ion channels you've learned that are stimulatory? Sodium and calcium. And it is both of those ion channels that open up in the heart. It takes two. When people are doing when heart surgeons are doing a heart transplant, so they take the bad heart out of a person, they're on bypass, so a machine is handling all the circulation stuff, and they got the donor heart and it's on ice. They warm it up first, of course, and they put it in, they hook up all the blood vessels. I don't know how long this takes. I'm sure I could Google it. Before they stimulate the heart, stimulate the pacemaker with a defibrillator, they bathe that heart with a sodium and calcium solution. So there's all the ions that heart needs for the pacemaker to depolarize. All right. And then they depolarize the heart. Hopefully the pacemaker starts, and then You got it. All right. It's pretty amazing. All right. Now, when the heart pacemaker repolarizes or rests, all right, so now it's acetylcholine binding to its muscarinic cholinergic receptor. What ion channel is important for resting the heart? Potassium. Stupid thing. And we talked about when there's too much potassium in the blood, hyperkalemia, that can actually slow the heart rate down a lot to the point of death, possibly. All right. Okay. Checking time. Pretty good. Now, we'll leave with this. This will be the last slide for today. Arrhythmias. That's what you're detecting when you're auscultating the heart. A person at rest should have a normal resting heart rate, and it can vary. If you've got a person who is a couch potato, doesn't exercise, doesn't train their heart, it's a muscle, it can be trained, and just like any other muscle in the body. An athlete, especially one who's a runner or long distance endurance athlete, might have a very low resting heart rate, as low as 50 something beats per minute. And that would be normal for them if they're an athlete. All right. Someone who's a couch potato might have a slightly higher resting heart rate because their heart's not been trained very well. Okay. Or if they have some disorders. All right. So they may have 80 beats per minute, and that'd be normal for them. So the normal range, it depends. Okay. And I have a clinical app, which I'll let you look at on your own. But if someone has tachycardia, that's a higher than normal heart rate. And I'm just going to put HR for heart rate because I think you all understand what that means. A resting heart rate that's very, very high. You can't let that go untreated. If I have to find out what's going on, because there might be some underlying issue. Of course, there's an underlying issue, but you do have to bring that heart rate down, because the heart, if it's going at a higher heart rate all the time, 24/7, 365, you can actually wear that heart out. The heart can actually thicken from over excessive heart rate, and that's called cardiomyopathy. And when the ventricle walls thicken, the heart doesn't contract as efficiently as it should. So that has to be treated. You have to bring that down. If heart rate's up, what happens to blood pressure? Up. Okay. You can't have that happen. There's a whole host of things that can happen if the blood pressure is too high. So treatments. Now that you know that the pacemaker depolarizes when epinephrine binds to its beta-1 adrenergic receptor and these ion channels open up, if you treat someone with sodium channel blockers or calcium channel blockers, you do not have to memorize the drugs. I'm just giving you a for example. Blocks those ion channels, slows the heart rate, brings blood pressure down. Or you can use beta blockers. We've covered this. We didn't test on it. It's going to be on the lecture quiz, the next one. What is a general beta blocker? It will block the beta-1 receptor on the pacemaker, but it also blocks the beta-2 receptors on your bronchioles. I'll start spelling it out and see when you cue in. Propranolol. Okay. It will decrease heart rate and cause bronchoconstriction. You don't want to do this drug on someone who has high heart rate, high blood pressure, but also has a respiratory issue, because it'll bring the blood pressure down by slowing the heart rate, but you'll also cause a respiratory crisis. Their airways will narrow. So this is a drug for someone who has high heart rate, high blood pressure, but no respiratory problems. You got someone who's got high heart rate, high blood pressure, and a respiratory problem, you want to give them atenolol. It will decrease heart rate, not affect lungs, because it's a beta-1 specific blocker. These are common. And this is all the time we have. So we'll have to pick it up on Monday because it is 10:20. All right. Have a great weekend. I'll see you on Monday. It's a beautiful weekend. Hope you get out and enjoy it.